Hi, everyone. On behalf of GU Oncology Now, I'm Brian Rini. I'm the Chief of Clinical Trials at Vanderbilt University. I'm pleased to be joined today by an expert panel of kidney cancer experts, and we're going to talk about really the spectrum of therapy for frontline kidney cancer, from observation and drugs, and also some of the new data, including triplets and what will be coming out in the next year. So I'm going to have each panel member introduce themselves, and we'll start with you, Dr. Ornstein.
Hi, I'm Dr. Moshe Ornstein. I'm a GU medical oncologist at the Cleveland Clinic, where I spearhead the RCC efforts.
Hi, I'm Shuchi Gulati. I'm an assistant professor at UC Davis Comprehensive Cancer Center. I'm really excited to be here.
Monty Pal. I run the kidney cancer program at City of Hope in Los Angeles.
Great, thanks all for being here. So, controversial topic, debulking nephrectomy. I think it's my least favorite topic now, right? I don't know, but we're going to cover it anyway.
Okay.
So as we know, there have been data back and forth for decades, about the value of debulking nephrectomy in kidney cancer. I'm still a believer in selected patients. I think it's always all been about patient selection. What do you think, Shuchi, about, are you using it in practice? Are you using it less since Carmina? How are you approaching it?
So you're right. It's a controversial topic. Definitely since the Carmina and Surtime results, we've backed off on how much nephrectomy was being done with urology. In my practice, patients who are symptomatic, if they have a lot of abdominal pain, if they have hematuria, they're definitely going to get nephrectomy. The others, I'm going to enroll them on the PROBE clinical trial because that's the trial that's trying to answer this question in our immunotherapy era. So it does definitely involve an extensive discussion with the urologist because you have to get them on board. They have a lower threshold to take these patients to surgery. So discussion with the urologist and also with the patients.
And PROBE, just to clarify, is nephrectomy you're not followed by, I think it's a modern immunotherapy-based regimen, is that right?
Exactly. You start with systemic therapy for 12 weeks, and then based on the response, they get randomized to either nephrectomy versus just continuation of systemic therapy. So that's made my life a little bit easier because I offered the clinical trial, and so, but it's definitely a discussion that needs to happen with the patient and the urologist involved.
Moshe, what do you think?
I think what the data have taught us is that there's still a role for cytoreductive nephrectomy, but it doesn't have to be rushed. So I look at the patients as extremes. I think there's three main categories. There's the category of patient that has 5 centimeter renal mass and extensive extrarenal disease and has fevers, chills, night sweats, just not feeling well from their disease burden. And that patient needs systemic therapy. There's no role for a cytoreductive nephrectomy. On the other end of the spectrum, there's the patient with a 15 centimeter renal mass and a couple of small things in the lung. And that patient's bulk of disease is in the kidney. Potentially with the nephrectomy, you can, again, do surveillance or observation, and you might be able to delay systemic therapy. And then there's the in-between patients. There's still a bulk of tumor in the kidney, but there is some extrarenal disease. And those patients, I have a discussion with them about, we don't necessarily need to do the cytoreductive nephrectomy now. We can try systemic therapy for 12 weeks. Again, I'm talking about off trial as standard of care for metastatic disease. And we can talk about a cytoreductive nephrectomy that's delayed.
Yeah, I think, by the way, you made a slide once that had those three categories that I still use to this day. Thank you. Thank you for making that slide. I think what I struggle with, I agree with what everybody said. I think what I struggle with is if they don't go to surgery up front, I don't really find them taking them to debulking nephrectomy later. I think when we get to systemic therapy, we'll talk about those patients whose only disease is left in the kidney. I think that's separate. But it's kind of like if they're doing well 12, 24, 36 weeks later, what am I doing? So it's all, for me, it's sort of upfront or not at all. I don't know what you think.
I think that makes perfect sense. It does actually influence my choice of systemic therapy to some extent. If I feel that surgery is imminent, maybe for some of the reasons that Shuchi outlined, the classic ones, pain, hematuria, perineoplastic syndromes, then I'll probably start that patient on Nivo/Ipi because I'll probably have to think a little bit less downstream about, stopping a TKI and bridging them to surgery and so forth. So if I have that sense that this patient is going to, be heading to the operating room, I do really try to tailor therapy accordingly.
Last question on this topic. You brought up PROBE. It seems like we keep repeating the same trials when we get new drugs. Do we need to keep doing that? Do we think PROBE's going to settle it once and for all, or are we going to still have the same debate 5 years from now where we say, well, it's patient selection and and bulk of tumor?
I think clinical trial data definitely helps us make a case when you're having that discussion with the patient. You can show them the numbers, and also with urology, because with like I said, with Carmina, I've definitely noticed, like once you have the trial data in front of you, you can convince the urologists to not jump the gun and take some of these patients to surgery. So I think in that regards, especially if it's a positive study, it'll definitely help. But you're right, it may just raise more questions because who are those patients? So we'll probably have a similar discussion, but that may be geared towards like who are those patients that might still benefit from surgery despite whatever the data shows.
I think it's one of those trials that we kind of need to do, right? Because it's a big morbid procedure that, maybe has the potential to benefit, but also has the potential to do harm. So I think, looking, 10 years from now, even if the trial's an utter failure because of, poor accrual or issues of actually getting patients onto the right randomization, at least we can look back and say that we gave it a shot in terms of defining this patient population.
Yeah.